and thank you for joining the Systems for Action Research in Progress webinar. My name is Chris Lytle, and I'm Deputy Director of Systems for Action. We're a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. We support studies across the country, testing tools and models to facilitate multi-sector collaboration across medical, social, and public health systems with a goal of improving population health and advancing health equity. Today we're joined by Dr. Daniel J. O'Connell, an assistant professor at the Department of Criminal Justice Center for Drug and Health Studies. And we'll hear about how they tested the impact of a referral program to link probationers to primary care. Multi-sector community networks are shaping COVID-19. Oh, excuse me, sorry. If you have questions for our investigators, please enter them in the Q&A box, and we will have time for questions at the end. We'll hear a presentation from Daniel O'Connor, and that'll be followed up by commentary from Dr. Patricia Becker. So with that, I'll introduce our presenters. Daniel J. O'Connor is a senior scientist with the Center for Drug and Health Studies and assistant professor in the Department of Criminal Justice at the University of Delaware, where he teaches criminology. Christy Vischer is director of CDHS and professor of sociology and criminal justice. She is a principal investigator of the 5-year NIDA-funded collaborative criminal justice drug abuse treatment studies. CJDATS is studying organizational strategies for improving the implementation of evidence-based practices for substance abusing offenders as they leave prison and return to the community. And our commentator for today, Dr. Patricia Becker, who is an assistant professor in the Department of Criminology at the College of New Jersey. Dr. Becker holds a PhD in criminology from the University of Delaware and a BA in sociology and criminal justice from LaSalle University. And with that, I will hand over the control to our presenters for the day. Thank you.
Thanks, Chris. We appreciate that, and we're happy for anybody's interest in this project. Before we get going, we want to thank the Robert Wood Johnson Foundation and Systems for Action in particular for their interest and support in this research. So today we're going to talk about Delaware's Culture of Health project, implementing a culture of health in Delaware. I will unpack this over the slides, but basically we wanted to, the question was, could we use the probation office as a site to reach out to disproportionately underrepresented individuals and access, link them to healthcare? That's really what we're doing. Now, to say that in excruciating detail, we start to study the implementation of a change team, and the 1, 2, 3, 4 here are you know, we were working across systems. We worked across 9 different systems as part of this, linking together different organizations and bringing them together in a busy urban probation office to link individuals on probation to healthcare. You know, and the whole idea, focusing on the cross-sector alignment goal of Systems for Action, was to reduce health disparities and inequities, because the people on probation are largely minority and largely underrepresented in health. And you'll see some of this as we go through the slides. So we focus on probationers because they're in the community, and we know that a large number of people are coming through those offices. And then we wanted to do all this, and then we wanted to test it in a randomized controlled trial to see whether it all worked. Next slide, please. Or wait, am I running the slides? I'm not running the slides. Who's running the slides? There we go. Okay, so we like to talk about this in terms of the people problem and the systems problem, right? A lot of attention is given to the prison population in the United States. You know, over 2 million people are incarcerated in the USA on any given day. And that gets a lot of headlines and things like that. But there are almost 7 million people who are on probation, who are under criminal justice control, and who are basically being supervised and reporting to a probation office on a known and regular basis. That was kind of what we used as the opportunity here. We know that probationers face many of the same health issues as incarcerated people, and they represent a traditionally hard to reach population. They're minority, they're young, they're under education, and they're underemployed. Next slide, please. I won't read all of this, but you know, there is some data on this stuff, and basically people on probation, much like people in prison, are more likely to suffer from a host of medical conditions, depression, anxiety, you know, more likely to be substance abuse involved than other non-probation people, much more likely to receive mental health treatment. So there's a host of issues. As a criminologist, I say the same types of things that led them to be criminal justice involved actually lead them to be more likely to be underrepresented in health. And by underrepresented in health, I mean less likely to have a regular doctor who they see on a regular basis. Next slide, please. I think this is just more data. No, it's not. Okay, so this is the system problem. Okay, health is not traditionally considered the responsibility of probation departments. Probation departments, you can go ask them, their job is to manage caseloads of people under a judicial sentence of criminal justice supervision in the community. But what it is a place where people, like I said, are on a regular and predictable basis. In Delaware, you're either showing up once a week or once a month, generally. And so, and we know when you're coming because you have an appointment with your probation officer. So, probation cannot take the responsibility of health screening and referrals. It's not their job. They don't have time. They have very high caseloads. But they can partner with a community-based health organization. Which is what we did in Delaware. We reached out to the largest health provider in the state of Delaware, Christiana Medical Services, and they were willing to come in. Others were too, and to work within the probation office to link people to healthcare. And that's what the Delaware Culture of Health Project is. So next slide. There are barriers to healthcare. It's some of the same ones. It's drug and alcohol history and mental illness. All of these are barriers to healthcare. They are studied and known barriers. People who possess these conditions are less likely to access healthcare on a regular basis, and people who are on probation happen to be at a much higher rate for all of these conditions. Next slide. All right, so the project worked like this. We put together a local change team. I'll explain that in a second. And it brought together a group of people who ended up doing a number of things. We created a Healthier You workbook, which I believe is available on the resource page at Systems for Action. And then we placed a health navigator in the probation office to link people to healthcare. And what they did, well, I'll talk more. And then we tested all this in a randomized controlled trial to see whether it worked. Next slide. So local change team is based on the NIATEX model, the Network for Improvement of Addiction Treatment. And it facilitates actions across agencies and systems. The original NIATEX was designed to work within one organization and how to improve practice, cut wait times, things like that, within one organization. And there's a system that you use, using focusing on one thing at a time, using rapid plan, do, study, act models, things like that. But what we did then, we engaged in team exercise. So we brought together 9 different agencies, people from the Division of Mental Health, Health Services, DSAV, Division of Substance Abuse and Mental Health. Local HIV clinics were represented. The Department of Labor was represented. The Department of Housing was represented. So we had a number of different people who were part of it. But as with most projects, you end up with a few champions. And one of the champions in this one was the medical providers. And really, because what we were doing was trying to link people to a regular doctor, because we know that people that get regular health screenings and engage with a regular family physician, general practitioner physician, have better health outcomes. So the whole idea is can we build on? So we created this team, and we met on a regular basis. And we kind of, Niatex works kind of like the university doesn't come in and tell everybody how they got what to do. The university fosters the change team, and the change team makes the decisions and looks at their own systems and develops approaches for kind of doing different things. Next slide. So the local change team in Delaware, the first thing they did, we identified buy-in and motivation as a key barrier. People they don't think about this. They generally, many of them use the emergency room. If they get sick, that's where they go. They're not in the habit of going to a general practitioner. They just access healthcare in ways that are different than many people. And so to create buy-in, we did a number of things. We created videos, and we actually put a TV in the waiting room of the probation office. So those videos that we shot, kind of public service kind of things about health and about the need for healthcare. We got some local people to talk about probation and using probation and doing healthcare appointments. So that all runs. The idea being that we got health in the minds of the people while they were sitting in their waiting room. So we also created this interactive workbook, which I talked about, the Healthier You Workbook, that became part of the study, that basically walks you through different conditions, what they mean to you by men and women, things about, high blood pressure, diabetes, anxiety, depression, mental health, substance abuse, all these different things are in there. And then within the workbook was information about local agencies on where to go get help. So we distributed that to people. Then we placed a healthcare facilitator on site to provide screening, and we offered people a short screen and then a referral to appointments. We would make the appointment right there. We had contact with the local provider, and we would call right from the probation department while the person was sitting there and make them an appointment. We would then follow up. Hey, you got an appointment tomorrow, to try to get them there. And we did all this. And the healthcare facilitator was paid for, funded by the grant. The university hired somebody. Actually, it was somebody that works with us. She's has a clinical background, and we put her in the office to do this work. And then we did a randomized controlled trial to see whether this worked. Next slide. All right. So basically, the hypothesis was this: that using an on-site practitioner will lead to a greater proportion of probationers accessing services compared to those receiving just the workbook, the Culture of Health workbook. So you got one of two things. You either saw the practitioner, Judith Buchanan, by the way, I will out her. She's a wonderful clinically trained person that we use for things like this. And we put Judy in the office. And so you either went down the hall and you saw Judy, or you received the interactive workbook. And the idea, because the interactive workbook in the text of the workbook in numerous places, it encourages people to make an appointment with the doctor, to go get screened, to go get tested, and tells them how to do that. It's all in the workbook here. So really, we're testing whether having the on-site practitioner versus the workbook, and H1 will not lead to a greater proportion of probationers accessing services. Next slide. All right, so we randomized 400 people, 200 per condition. And again, the condition one was the workbook. Condition two was the referral to a health practitioner. Oh, everybody got the workbook, by the way. We handed those out to everybody. So that was just whether the addition of seeing the practitioner led to a greater likelihood of you accessing healthcare. We used electronic health and Medicaid data and we got treatment access across agencies for a number of folks. But again, the main thing we got was the local hospital, who has a very good data system. And Delaware is, just so you know, Delaware is a small state. So basically, the main hospital health network in here, the vast majority of people use, and they take Medicaid, and so people generally, that's where they go. They've got 2 hospitals in Newcastle County, one in downtown Wilmington, one in the suburban area. So if you live in this area, this is generally how you access your health care. We also conducted a survey of probationers about health-related needs and about insurance. I'll show you some results of the survey in a minute as part of the outcome. And then Tricia, as part of the work she was doing, went out and conducted semi-structured interviews with a subsample of people to kind of get some nuance and some qualitative data on that. She's working on a paper that'll be published at some point on that kind of stuff. So next slide, please. I think this is just the, I like design slides. I tell all my graduate students, draw your model. So this is kind of what we did. There's the probation, the randomization. You either got the workbook or the group. And then at a midpoint through the study, we added an incentive. It wasn't much, I think it was $25, to receive an incentive or not receive an incentive within each condition. We have not analyzed that data yet. We're still working on it. And then the outcomes there are, did clients present for an appointment at a health facility? We didn't go beyond that. We didn't actually do health outcomes because it was a limited study, both in time frame and in scope. So really what we wanted to see, could we make that initial handoff, is what we're looking at here. Next slide. And there it is. We randomized 403 people, 73% male, 66% minority, and that is kind of pretty much in line with the probationers in Delaware. Next slide. All right, here are some survey results from questions that we asked. We'll go through these. Generally, people consider themselves healthy, but not very healthy, in the healthy, somewhat healthy frame, which is a good sign. And we asked them whether they had primary care doctor. More than half of them did not. 44% said they did, but 56% then said they did not. Next slide. And then reasons for not having a doctor. Interestingly, this one kind of surprised me. A full third of them said they basically don't know how to find one. It's outside of what they do. And you know, it's like, how do I even go about getting a doctor was the response. We got transportation issues, time issues came up, cost, no insurance by a pretty large group of them. A small group said, you know, that they were worried about what they might have. And then you see down at the bottom, 44% of people said that they had a primary care physician. And then the other slide, there's some health conditions specifically we asked about. High percentage of people had depression or anxiety. You see these mental health issues coming to the core there. PTSD, bipolar disorder, all very high among this population. So clearly this is a group of people that we need to get connected to healthcare so that they can get treatment for these things. Next slide, please. We asked the usual source of medical care. 51% said they had a primary care doctor. It was actually higher than I thought it was going to be, but still pretty low compared to the general population. And one of the things that surprised us and really surprised our healthcare provider was that 28% of people use their main source of medical care as the emergency room. That I said earlier, this is where they go when they get sick or something happens. They just go down to the emergency room, which is the last thing the emergency room people want you to do. They want you to go for emergencies, not when you have the flu. And so that is something we definitely want to work on. And then we currently have health insurance. You see there, about 70% have Medicaid. Much smaller number through work or through family. but and then 18% have no insurance whatsoever. Next slide. Okay, so then from the randomized trial findings, what we found, 80 people out of the 403, about 20%, attended the doctor's appointment. That's the full sample. Okay, breaking it down by condition, 23% of people in the treatment condition, that is people who met with the practitioner, had a subsequent appointment with the doctor, while 17% who just got the workbook made an appointment with the medical doctor. So the chi-square was encouraging, 0.09, but it was not greater than or less than 0.05. So we're close to significance, but not quite there. We got to thinking about it, and one of the things we heard in the interviews and other places was essentially that some of the people we screened and that met with the practitioner already had a doctor, so they were like, well, I'm not going to go see a doctor because I already have one. So 53% there, you see, they already had a physician. So we screened out and did some analysis on the 176 people who did not have a doctor. And what we found was that 26% of those people made an appointment after seeing the practitioner, while only 10% of that group who got the workbook only made it to the doctor. So of the people who are kind of eligible to actually make an appointment with the doctor, we see a much larger split, 26% to 10%, which was highly significant, less than 0.01, and very encouraging from where we sit. A significant finding, a modest effect, but still a significant effect both statistically and we think substantively. Next slide. So we learned some things about this. The correctional organizations, they were willing and able to coordinate with the health agencies. They were on board with this. They recognize that they've got these people in their office. They say, hey, yeah, these people need health care. And if you want to come in and work with them, that's fine with us. Like I said, they have very high caseloads. They don't have time to do this work themselves. But they were willing to work with us and provide an office and allow us to hang posters on the wall, do the TV things. They gave us a really, really high level of access to the office to do this study. And healthcare organizations, state health agencies were also willing to work on this. I guess the thing to say is that the opportunity is there, the people are there, and the people are willing. It's not at the top of their mind. So somebody from either a community-based agency, a health agency or something, or a university set of researchers, if you go knock on the door, I think you will find those doors open that people are willing. And we demonstrated proof of concept with this. When we would like to go back and do a much larger study. We've kind of gotten sidetracked by some other things, and then we got sidetracked by COVID. But we would like to go back and do a larger randomized trial and look at health outcomes as a result of this. And we're hoping to get there some way. Basically, there in the purple at the bottom, what we found was that placing a health mentor in a probation office significantly increased the likelihood of a probationer attending a healthcare appointment. That is the money line from the findings. Next slide. Okay, sustainability. Resources were not currently available to maintain an on-site mentor in the probation office. We reached out to people. Again, the probation office couldn't quite do it because, again, they would have to fund a full-time or close to full-time person to go do that work. The healthcare agency was willing. But when it got down to it, they really couldn't quite pull it off. So the thing kind of has lost momentum. I will say what we did, that we were working with the Delaware health agencies, the health department, and they have placed somebody in there 3 days a week to do HIV and hepatitis C screening. So that is what has happened there. We're not doing the referral to treatment, but as a result of this project, that HIV and Hep C screening is still going on. It's currently shut down due to COVID, but we anticipate that it will come back when things open back up again. Next slide, please. Oh, hey, there you go. So thank you for letting us speak about this. Again, we want to thank Robert Wood Johnson Foundation Systems for Action for supporting this project. It really was a good project. We felt we learned a lot. And hopefully we are just laying the groundwork for something that others can come behind, take the proof of concept, try it in other locations, and expand what we're doing. We're really hoping to see that happen. Hopefully some of you that are on this can take that mantle and run with it. Patricia Becker has agreed to speak. I will let her be introduced by the moderators. So thank you for your time.
All right. Thank you, Daniel, so much. We can go along to our commentary with Dr. Patricia Becker. Quick reminder, if folks want to ask our presenters any questions about their study, feel free to add that to our Q&A. And with that, I'll pass it along to Patricia Becker.
Hi, everyone. Thank you, Chris, for passing it along. So some comments that I just wanted to bring up is really to give you all an in-depth look at the different interviews that were conducted based on this project, to shed some more nuanced light along with the quantitative findings that Dan had already went over. So as we conducted these interviews, this really led us to expanding some lessons learned. So as you know, we were originally trying to link individuals to primary care physicians. And really the idea behind that was that then that primary care physician can then refer that individual out to any other sort of health needs that they may have. However, really upon talking with people, they were more interested in other pressing needs rather than seeing a primary care physician. Even though they understood the importance of that, a lot of individuals had immediate dental needs that they needed taken care of. Women wanted to see a gynecologist. Vision was another big thing. So along with just linking to primary care physicians, as we made appointments with them, we also let the health navigator at the Christiana Care System Network know of that most important need that that individual had. And they made appointments along with the primary care, but also if they wanted to see dental or vision or a GYN, they were able to make multiple appointments. And I think that was key in the data that we received from the Christiana Care Health System. We didn't get any sort of data on what was going on with the individuals. We just got a yes or no, did they attend a doctor's appointment and what type of doctor's appointment they attended. So what was really interesting in this data was that we saw multiple people not only just attend one doctor's appointment, but had 6, 7, 8 doctor's appointments alongside. So we had people getting x-rays, dental, vision, GYN, along with their primary care physician. So we really felt good about the findings and that, yes, we linked them to primary care, but then we saw that not only did they attend that appointment, but they were also attending multiple appointments after that initial appointment. So we really linked them into that healthcare system. And then another really important thing that we learned from these qualitative interviews was that, yes, we saw a little over 40% of the individuals say that they did in fact have a primary care physician, but when speaking with them and understanding what they meant by that, a lot of times people didn't even realize what a primary care physician was because they didn't grow up with that in mind. A lot of the individuals talked about, well, I didn't grow up going to a primary care physician. We grew up going to the emergency room if we had a pressing health need. So that was really interesting to learn that this is just something that individuals did not grow up doing. or utilizing. So they continued that process along into adulthood. And as talking to them, a lot of individuals wanted information for their children, not just themselves. So talking with Dan and Christy about expanding the project maybe into some community centers and things like that. So not only can we help maybe individuals on probation, but we can also help link their family members as well, and kind of break that cycle of utilizing the emergency room as their source of primary care. So not only was it something that they did not grow up doing, but they also had a sense of, what is the right word here? Like nervousness attending these primary care physicians. One of the first questions that was asked before we made appointments was, are you going to tell the person that I'm on probation? Are you going to let them know about my criminal past? And obviously we said, no, if you want to disclose that, feel free to do so, but this isn't something that we tell anybody. And so there was a sense that doctors really didn't understand the different intersecting identities that come along with having a criminal justice background when individuals went there. So I think expanding to make sure that healthcare providers are educated on the different barriers and health outcomes of of our criminal justice populations, as we can see from the slideshow, that these individuals have increased health risks, and I think our healthcare practitioners need to be aware of those and different barriers that this population faces. So that is all for the commentary that I have, and we're really excited to go over some of the questions that you all have for us, and hopefully we can give some good answers to those questions.
Thank you both so much for sharing this really interesting study with us. Again, folks, if you would like to have any questions answered, please feel free to add those to our Q&A box for us to have the presenters respond. I'll start with the question. One thing that I noticed about this study was it was very clear what the individual barriers were for people on probation to be connected with primary care. I'm curious if either of you could speak a little bit more to the systems level barriers to accessing care and kind of how that informed your study as well.
Can you repeat that last bit? I got confused.
Yeah, sure. Just kind of high level. What I took away was, the impetus kind of this study being some of the individual barriers that folks on probation have experienced that make it more difficult for them to connect with primary care. They're younger, may not have steady employment, housing insecurity, and yet they're high need. I'm curious to hear a little bit more about any systems level barriers that make it difficult to connect folks on probation to primary care, and whether that impacted the design of your study at all, or if it informed the design of your study at all.
Certainly go ahead, Trisha.
Okay, so one thing, so first off, that's a great question, Chris. One thing that I definitely think came out of a system level barrier that maybe we weren't anticipating is just how much time individuals on probation spends at probation, and through their other requirements, how little time do they have left over to attend these additional appointments. So as we were going through the process and talking with individuals and in the interviews and meeting with people and understanding why did they cancel an appointment that we had set up for them. And a lot of times it was, well, I had to meet with my probation officer, or because I have to meet with my probation officer and I have to do these other counseling sessions that are set because of my probation, that I can't miss all this extra time of work. Or they have multiple part-time jobs, and then when they get the call that there's a shift available, they're going to take that shift over attending a doctor's appointment. So one systemic barrier, I think, is just the requirements of probation. And this is like the double-edged sword, is that we know that individuals have all of these requirements of probation, and we don't want to add, and that wasn't the purpose or goal of the study, was to add another requirement of probation that they attend these appointments, because we didn't want any individual getting in trouble for not attending these appointments. But then you think on the other side, well, if it was a requirement and we can get them to attend these appointments, and then they have positive outcomes based on attending those appointments. So it's really just a double-edged sword of that they already have so many requirements. And so really adding on one more thing to the everyday people may not seem like that big of a deal, but for these individuals that have so many other requirements that take up so much time, it really was a struggle for them to balance keeping the appointments or making an appointment on their own with everything else they had going on. So I think we didn't anticipate that from the onset, but quickly learned through the interviews and through talking with people that a systemic barrier was just the requirements of probation, and really how little time they had after they completed those requirements to add on an additional appointment to attend.
Yeah, I can follow up a little bit on that too. Another thing that gets to the time issue a little bit that Trisha was talking about, the location of the probation office. It's kind of weird. Delaware, the probation office used to be located right in the heart of downtown Wilmington, which was pretty easy for people to get to. They then moved it outside of the city. So it's an urban probation office, but it's just outside the city. And transportation is an issue because you have to take a bus to get out there. So for somebody to come and do a 15-minute appointment with their probation officer can easily take half a day. By the time you ride the bus out there, you can sit for a long time in the waiting room, and then ride the bus home. It becomes quite an undertaking for these folks to do. So all of that presented barriers. One of the other, like from the really 30,000 foot level, not so much probation, although these people cycle in and out of the institution, is Medicaid. And Medicaid, you lose your Medicaid when you're incarcerated. And Delaware is working on, but they haven't managed to do it yet, getting people signed back up for Medicaid so that you have it upon release from incarceration. All systems should be working on this. Delaware's working on it. They've actually gotten to the point where when everything's working properly, people have filled out the forms, all the Medicaid forms and all of that stuff, but they have to go to the Medicaid office, which is located kind of in a weird spot in the city, outside the city. You have to go down and sign and actually make the thing live. And they can't get that last step somehow to be done while they're incarcerated. So all of those kind of systems level things are barriers that can be and should be addressed in projects like this. Did you folks, am I supposed to work through the questions that are in the QA, or how are we doing this?
Oh, no worries. I can help you out. I'm sorting through them, and I'll pitch you some of the good ones as time permits. Great responses. That's exactly what I was trying to get you all to speak on. Daniel, I'll send this one to you. We were actually talking about IRB on the call before your presentation started. Heather Stocker is interested to hear about the IRB process and whether that was particularly challenging or if it was a barrier, and how long that process took for you as well.
It was actually not particularly challenging because to be in the study, we consented everybody in the study. So our IRB, their main thing was like So you're explaining the study prior to any of the work that you're doing, and only working with the people who consent and volunteer to be a part. So to get, even before you got the workbook, we had all the, the TV was going and the things like that. Judy and Trisha would go out into the waiting room and make the announcement that we were doing this study. And if you were interested in talking to us, we would appreciate that. And when somebody raised their hand, the first thing we would do is consent them. We would consent them. We would give them the survey, and then we would randomize them. And so the IRB, as long as the consent was done first thing, they were okay with it. And that kind of gets to another question that's in there about data. Again, the only data that was shared was between the health organizations and ourselves. We did not get criminal justice data as part of this study, because frankly, we weren't. Recidivism is the big thing. But for this particular study, we weren't interested, because we were trying to look at medical care. So we didn't even get their criminal justice records. The only thing we got was the health records of the people. And even then, only whether or not they presented. We didn't get anything on conditions except what was on the survey. And so we kept the level of data exactly where we wanted it to see. Did the linkage to care work? And all we needed for that was, did they present for the appointment? And so the IRB was actually fine with this particular one. We've had some other studies that were more challenging. But, next question, please. I'll let.
Awesome. And I'll direct this question to Patricia. I think you spoke to this a little bit. Did you find that people were hesitant to engage and disclose personal health care information at a probation office, particularly conditions that may have impacted their freedom, i.e. SUD, mental health services? And how did you assure them that healthcare services were divorced from the criminal justice system and that services were not coercive?
Yes, that's a great question. So once we let the individuals know that what they were, so their survey was anonymous, it did not have their name on it. And then the interviews obviously were anonymous as well. So once individuals knew that and knew that none of the information was going back to probation, that is strictly if they wanted to make an appointment, then we would make that call for them. But other than that, their name was not on anything besides the consent form. They felt more comfortable. Now, I'm sure that they disclosed more information if they attended this appointment, obviously to the healthcare practitioners that they talked to rather than us. But people were hesitant at first. And once we assured them that nothing was getting back to probation, nothing that they told us was getting back to probation, we were strictly using that location to talk with individuals, and because they gave us a private office. So that is really why we set up the study, that we would go into the waiting room, give them a little bit in brief synopsis of the study. Hey, we're interested in talking with anybody about healthcare and primary care physicians. There's an incentive involved if you fill out the quick survey. Is anybody interested? And then if they raise their hands, we took them into our private office to then go over the consent form and for them to fill out the survey. So I think that they felt more comfortable realizing that A, we weren't, their name wasn't on anything besides the consent, and B, that they were in a private location and their probation officer was not present in the meeting with us, whether that be just to fill out the survey or if they were actually going to do an interview as well. Now, when the waiting room was more crowded, we did notice it was kind of harder to get participants to come back and speak with us. But typically, once we got one or two and individuals saw that, hey, it was quick, painless, they came back to the waiting room, no problem, then everyone else, I think, felt more comfortable coming with us. But there was that initial apprehension, is my probation officer going to find out about this? And do you tell them anything? And once we assured them that, no, we do not, and B, hey, look, this is the survey you fill out, and in no way do you put your name on this. And then we showed them where we kept the surveys and that it was locked up, only we had the key. And then after we recorded all the data, and the interviews were transcribed, they were destroyed based on the IRB. So once we really gave them that information, they felt more comfortable with us. And then to know that the services were non-coercive, we just made sure, hey, this isn't something that you need to do. After you fill out the survey, you do not need to make an appointment at all. We just tried to give them the information that they needed and understand what was going to occur at that appointment. So Judy and myself attended walkthroughs for every sort of appointment that individuals could make. So whether that be with the HIV Center in Delaware, Planned Parenthood, the Christiana Care Network, we saw the vision and dental setup. So we could let them know exactly what to expect when they attended this appointment, from how to get, when you walk into the hospital, you're going to turn right and then a left and you're going to see this sign. So I think once they realized that, hey, we were giving them really in-depth information on not only what they can get out of, but also what to expect at the appointment. And then also just assuring them that you don't have to do this if you don't want to. You don't have to make an appointment. You don't have to follow through. But these are some good things that can come out of the appointment, and just giving them all the information really equipped them to make the choices that they wanted to make, whether that was attend the appointment or not. And we had a lot of individuals come back after seeing us and passing at probation, just let us know, hey, we attended that appointment. It was exactly what you said it was going to be. And it really just was comforting to us that, they had a good experience and it was something that they wanted to do and they weren't in no way forced to do it.
Thanks, Patricia. And Daniel, did you want to add anything?
No, I think she covered it. She took me back down memory lane a little bit about how well the team was at explaining all this stuff. And really, and Tricia nailed it. They didn't have an apprehension. They're going into the unknown for many of these people. Well, you want me to do this? What does that entail? What am I signing up for? What am I doing here? And partly because of the knowledge that Tricia and Judy possess by doing all the walkthroughs, they really were able to allay some of that stuff. And interestingly, when we stressed the voluntariness of the study, they seem more likely. It's probation. They're used to being coerced for stuff. So we're like, we don't care if you do this or not. We're just, they're like, oh, well, okay. Well, then, yeah, that actually kind of raised their eyebrows a little bit and made them more interested. So.
All right.
And just to follow up with that, Chris, a question just came in from Liz. To attend the appointment was not a requirement of probation. I mentioned that as like a double-edged sword, that we definitely did not want to make it a requirement, because if individuals could not attend the appointment, then we didn't want them getting in trouble at all with probation. So probation officers didn't even know who was participating in the study, or did they make an appointment. We didn't share any information with probation at all, and it was not a requirement.
Yeah, I would stress that too. You would lose legitimacy in a hurry if people knew that you were reporting back, even if it wasn't a requirement. If you were just like giving them a list, hey, these are the people we made the appointments for this week, and you were giving them and probationers knew that, they would opt out in a hurry, because they are by definition a little bit apprehensive about where they are and about their relationship with the probation people themselves. They were fine with us and with the healthcare people we were working with. And so, yeah, it should not, I should stress that, it should not ever be a requirement of probation to do any of this stuff, but rather making it available, using the space, the location of the probation office, using access to the population on a voluntary basis to offer these types of services is the way to go, but not to interact with the probation team in an identified way where you're like, hey, these are the people that are going this week, or certainly not to make it a requirement of probation that you cooperate. None of that should be happening.
Great. And we'll do a few more of these. Could you speak to the time and attention needed to establish the local change team and the whole infrastructure needed in order to implement your intervention, and whether you had any difficulty with the culture of the probation office.
I'll take a first stab at that. The time, we met fairly regularly at first, and it tapered over the course of the project. When we first got the group together, you know, we had a number of brainstorming sessions. You know, we generally met at lunchtime and provided pizza and salads. Got to be healthy for everybody, and kind of walked them through the change team process. And they really kind of they dug in a good way. By dug in, I mean like really got involved, and wanted to try to make this thing work. It's kind of interesting. I've done a lot of work in criminal justice agencies with police and corrections and courts and things like that. And then this was the first project where we really work a lot with health practitioners. And it's interesting to see the attitudes of the health practitioners compared to those of the criminal justice people. Really kind of a strange dynamic there. So meeting weekly at first, but not for long. It tapered pretty quickly after that, and we would meet once a month. And then even that tapered as time went on, because once we got things set up, you know, it was kind of able to run. So I don't remember how many months it was. It was several months, 4 or 5. It's written down somewhere to get the whole thing up and running. And then it was really just about conducting the trial and doing the workbook of the practitioner. So that part. So a lot of work at first, but not on an ongoing, like, long basis. So you need commitment of your implementation team in the beginning to be hands-on and ready to come to meetings and interact by email and things like that in the beginning. But then that tapers over the course of the project once you stand up whatever it is you come up with. And these models can vary. The way we did it here is probably one. And there was another piece of that question. I forget what. Oh, the culture of the probation office. I'll let Tricia talk some about this if she chooses to. There was pushback among some officers. So there's, you know, obviously not all probation officers are the same. Some probation officers were very bought in. Many were just kind of indifferent. And some were actively kind of hostile to us up there. You know, my people don't have time to be doing all this. Why are you doing this? Why are you here? That kind of thing. We did get some. There were a few that got some pushback. Tricia, do you want to comment on any of that? Tricia was in the office much more than I was. So.
Yeah. So like Dan said, there was pushback, and this seemed to be more in the initial as we first went into probation. And I think it was just mainly from a lack of knowledge on the probation officer's endpoint that we were actually coming in and what we were attempting to do. So I think we curtailed this mainly by having some information sessions with the probation officers, and then they received some educational points that they have to get so many for attending these sessions. So there was a buy-in for them to come because they were getting these points, but then also we had the chance and opportunity to really explain to them what we were doing and how quick of a process it was. Individuals weren't in our office for more than 10 minutes. And when we did the qualitative interviews, we scheduled that after. So a lot of times they came in to do these interviews maybe on a time that they weren't even coming to see their probation officer, or if it was, I worked with them, said, hey, you know, meet with your officer first. That way there's no issue. And then I will come and keep an eye out in the waiting room. And when I see you back, then I'll take you in for the interview. Just because, you know, they range in time and you just don't know how long the interview may last. I mean, upwards, some of them were an hour plus. So we really tried to understand that probation officers had a job to get done, and that we didn't want to impact or in any negative way that job, that they have so many people they have to see and they run a tight schedule. But also I think they really needed to understand why we were there and what we were offering to these individuals, and then how quick it was. So after speaking with them and letting them know about the project, you know, it was a lot less pushback that we got. And I think they appreciated us coming to them and giving them the information about the project. And then we also gave them some workbooks and stuff and said, hey, you know, if you think anybody that you have maybe, you know, need the services that we're providing, if they don't have insurance, and because the workbook gave them information on how to get insurance, the phone numbers, all Delaware specific, you know, then they were able to pass out the workbooks as well to people that they thought needed the information. So sometimes we were getting referrals from the probation officers like, hey, you know, I met with so-and-so today. I told them that they really should see you. They may be in the waiting room still to see you. You know, so it worked out, you know, after we let the officers know really what we were doing and what our goal was, then we had a lot less pushback. And then even some officers were, you know, telling the people that they saw, like, hey, you know, I don't know if you heard, but we have some people here from the university that are doing this study. You should really think about participating if you haven't already. So it worked out to take that extra step and meet with the officers and give them the information.
Okay, thank you for the response, Patricia and Daniel. We'll stop there. We have quite a few questions come in. We'll share the slides with you, and you'll be able to see a recording of this as well. And if you have any additional questions for either of our presenters today, feel free to reach out to us and we can get you connected. So thank you again to Dr. Daniel O'Connell and Patricia Becker, and to Dr. Christy Vischer also for your amazing work. Yeah, thank you so much.
Thanks, everybody.
All right, a few announcements while we have you. If you are interested in learning a little bit more about this study and how to take the findings into action, our program office, along with the support of our investigators, have created an evidence brief based on their study on testing the impact of a referral program to link probationers to primary care. You can find this evidence brief at our website, systemsforaction.org. We'll be adding these evidence briefs momentarily for other projects. So keep a lookout for those, but in the meantime, check out this evidence brief. Folks are interested in a certificate of completion for today's ResProg webinar. Please complete the survey at the end of the session. It should pop up, but we'll also email you a survey as well, and we'll be able to get that certificate to you as soon as possible. And hopefully you'll be joining us again for our upcoming webinars. Our next one, same time, same place, September 16th, we'll be hearing from our team out of Texas A&M University, Drs. George Nuffel and Emily Naser. They'll be discussing how to address the health and social needs of justice-involved young adults. And September 30th, we'll hear from Alicia Bunger, Dr. Alicia Bunger from Ohio State, about using regional governing boards to align services for rural children of the opioid crisis. And of course, we'd like to acknowledge the Robert Wood Johnson Foundation. Systems for Action is a national program office of RWJ. Thank you all for showing up and asking great questions. And we look forward to seeing you, or at least sharing with you September 16th. Take care.